of explaining what the mission is of Rural Health Care Initiative and how it got started. Okay, so the mission is to partner with rural communities in Sierra Leone, and I'll show you where that's at, in redeveloping healthcare systems to overcome one of the highest rates of maternal and child mortality in the world. So it's kind of a big ambition. So the country of Sierra Leone is located on the west coast of Africa. You can see up here. It's right next to Liberia and Guinea. And it's a small country. It's about the land size of South Carolina, and the population is close to 8 million. So it's a little bit bigger population than the state of Minnesota. And then within the country of Sierra Leone, when we travel there, we fly into this Lungi airport and then travel to Bo, which is kind of the big city in the area where we work and where the hospitals are located. And then the area we work in is south of Bo, which is called the Tikonko Chiefdom. So that gives you a little spatial orientation there. So it's a former British colony and went through a devastating, it got its freedom from the British in 1962, which is now like, or 61 because they just celebrated their 62nd anniversary of freedom. Kind of like when we celebrate the 4th of July, they celebrate the 28th of April as their Independence Day. During the 90s, there was a terrible civil war that happened, and it had to do with Liberia and Charles Taylor and blood diamonds, and there was 4 different groups that were fighting each other, and at the end, nobody could even tell who was even in each group. So they did finally, through the United Nations, come to a level of peace, went through a truth and reconciliation program similar to South Africa. And since then, the country's been rebuilding because lots of things were just destroyed. In fact, the town of Tikonko, which is kind of in the middle of the chiefdom, on June 28th, 1998, it was burned down, and they have a big mass grave where all the people that died that day are buried. So it's a country that's been through a lot. And then during the Ebola outbreak, it was one of the 3 countries that was severely affected, with over 4,000 people dying, including many health workers. And then of course COVID set everything back too. So it's been a lot of barriers there. Okay, whoops. Or the wrong arrow, I guess. There we go. We just did that. So I'll skip that. So back when we first started working on these projects, the maternal mortality was such that about 1 in 17 women during their lifetime would die related to childbirth or pregnancy. And at that point, it was the highest in the world. And 1 in 8 children did not live to the age of 5. And the Human Development Index, which is composed of 3 things: life expectancy, literacy level, and like economics, like income, was 182 out of 189. And life expectancy is around 55. Literacy rate lower in women than men, 35%, and men 51%. And we've discovered that even when people say they're literate, they aren't very literate. It's hard to even call them that because reading and writing is very limited. But there is hope. So in 2019, there was a lot of improvement shown in women not being as likely to die during childbirth. And so even over the last few years, it's come down significantly. I can't give you a level, but we really think that we are a small piece of that improvement. So what is Rural Healthcare Initiative? So it was founded in 2011 by Alice Carpe, and I'll tell you her story in a minute. It's a 501c3 nonprofit organization, so you can give and get a tax deduction in Minnesota. And then it's a registered NGO or non-governmental organization in the country of Sierra Leone. We've been registered there since 2013. Every year we have a volunteer trip, except the year of COVID and then in the year of Ebola. So there's several years there where we couldn't go over and to advance our work. We currently have 19 full-time in-country staff and over 60 part-time. And funding comes from individuals, churches, fundraiser events, community organizations, small family foundations, and we've gotten a few small grants. But what I really want to tell you about is Alice's story, because that's the story of RHCI. So Alice is about my age. She's actually 2 years younger, I think. But she was born in Tikonko, in this very rural area of Sierra Leone, and I was born, well, in North Dakota, but at least we had access to healthcare. So she had seen so many women and children die when she was growing up that she had this dream that she would do something to help the women and children in her village. Well, she was in a poor family. She got married at 17, had children, got divorced, got remarried, moved to Liberia, and then in 1993, they had moved back to, it was 92 or 93, moved back to Sierra Leone, and her husband was assassinated during the war. He was in the military. So she's got 5 of her own children and then 4 stepchildren, and she was able to get asylum through the United Nations, and they placed her in Philadelphia. So she came to Philadelphia in 93 or 94, I think it's 94, with 9 children, single mom, and just had to make a go of it. The kids got educated, she worked at group homes, and eventually they moved from Philadelphia to Minnesota, and then she got her LPN degree and started working at University of Minnesota Student Health Center, and that's where I met her, is there in about 2011 or 2012. So once her kids were all raised, she decided now's the time. If I'm gonna follow my dream, I gotta do something. So she sought advice from a lot of different people and was able to be the founder of this organization through the Sierra Leone community in Minnesota and through a lot of her friends and colleagues at Boynton Health at the U. So I got involved in 2012 and took my first trip to Sierra Leone with Alice in 2013. I think I probably spoke here up like in 2014 or 15, back when we were just kind of getting things going. So I'll go through more here now. So we have 4 key program areas, and I'll show some slides and pictures from each of the areas. And this has evolved over time. But the 4 areas are rural health system strengthening. I'll explain what that is in a minute. Birth waiting homes, and we have 2, one in Tikonko, one in Gundama. A children's health program and a malnutrition program, and then a small food security and agriculture program. So starting with health system strengthening. With such a poor country, the government's not able to supply its clinics with all the medications, medical equipment, with most of anything that they need. In fact, when the first time I was there, we went to the clinic right in Tikonko, and they had no running water, no electricity, were delivering babies in the dark, and they had no gloves. It was like, whoo! I thought the needs were just like unfathomable, that there was such a lack of healthcare, and that some of the advanced diseases we saw in adults was mind-boggling. So obviously then it's like, it's a great opportunity to do something if you see all these needs, and they were very much welcoming to us to partner with them. So a lot of what we do is in partnership with the local government-run health clinics, and there's 4 different ones that we partner with and help bring supplies. So basically that's what this is, medical resource donations. So every 4 months we send 3 or 4 barrels of supplies, medical supplies and baby kits over there. And then we've done a number of trainings for the healthcare workers and community health workers to help strengthen their system. And transportation turned out to be just really huge. So if you don't have transportation, you can't get to a clinic or a hospital to deliver your baby. So we now have 3 4-wheel drive trucks and 4 motorbikes and 4 different drivers that alternate their schedules so that we can provide good transportation. So an example would be if a woman was at the local community health center delivering her baby and she was hemorrhaging and they couldn't handle it, then they would immediately call for one of our trucks to transport her to the district hospital where she could get the advanced care she needs. So without transportation, you just don't think about this. How do you get from point A to point B? Most of it's walking over there. So, and then the motorbike outreach clinic. So start out with motorbikes. We now use the trucks, but it's to 8 different villages, 1 time a month. So on Thursdays, there's 4 villages that rotate, and on Fridays, 4 villages that rotate. So it brings some of the healthcare right out to the villages instead of people having to walk miles and miles to get healthcare. And then we also provide some support to these 2 remote clinics that are kind of at the edge of our catchment area. So this just shows some of our transportation. On the first picture here, this is Mohammed Kaba, one of our outreach coordinators. And this box is almost certainly a big supply of medications that he's taking out to like Casamar or Semba, one of those remote villages. And then this is the first truck, 4-wheel drive truck we had. And then kind of quickly outgrew, needed more than one to be able to service the large geographic area we've been serving. And so and then we bought a second used Land Cruiser, and this is our 3rd truck now, which is a new Land Cruiser that was donated by a very generous individual. And this is when we were there just a few months ago and all our luggage was tied to the top. And this actually is, the last couple times I stayed at a hotel that's close to where we work. In the past, I used to always stay out in the village, but it's hot and it just got too hard on me. So I now stay at a hotel. So this is an example of some of the trainings we do. This was from this last February where we were training in basic neonatal resuscitation, like the first minute of life, getting the baby breathing. So we trained 18 medical staff with that. Here's one of our, Marie over here. Now Marie is an interesting woman. She's 30 years old, single, and she works as a nurse, but she developed this huge breast lump, turned out to have breast cancer, had a mastectomy, and has been going through chemo. So she doesn't have any hair on there, but we're hopeful that she'll survive it all. The motorbike clinics actually now it's more like the truck clinics, go to those 8 villages and over 150 individuals, and that's a combination of children and pregnant women that are seen and treated each week. We expanded the age range. The most vulnerable people in the population are considered to be pregnant and lactating mothers and children under age 5. But just in the last year, we expanded it to children through age 10 so that a larger group of children could get the care they need. The most common illnesses are malaria and respiratory infections, but there's many others too, such as diarrhea, dehydration, sepsis, pneumonia, even neonatal jaundice too. And then we have the malnutrition program that I'll show a few other pictures of with over 200 children served this past year. And we go by World Health Organization guidelines for all those programs. So this picture over here is from just last February. It's a young mother with 4 children. I'm not sure if a couple of them were twins or not, because she was speaking Mendi and I was speaking English, so we had a little difficulty in our communication. But this was at one of our outreach clinics in Magbima. Very, very busy clinic. That day, I think they saw over 100 people. And they did it, the clinic kind of in homes and places where they had some shade. So it was kind of a spread out clinic area. And when they were doing the prenatal visits, they would have the pregnant woman go to this local home, the mattress on the floor, and do the evaluation there. So it was kind of basic. This is another day at the outreach clinic when we were there, and this is in Ballyhoon. And this was a kind of a thatched roof structure where the clinic was being held. And of course, everybody's huddling in trying to be in the shade because it's really hot, like 100 degrees. And this is one of our trucks here. But that day was really interesting. We went to the outreach clinic, actually both Magbima on Thursday and then Ballyhoon on Friday. And we got there about 10, and it was really busy already because the healthcare workers and staff were already there seeing people, mostly children, and doing malnutrition evaluations. But by noon, they had identified 2 children that were very seriously ill. One of them was, they both had malaria, but one of them was really breathing fast, was in some respiratory distress. And the other one was just so lethargic, you could hardly wake her up. And she also had, she was severely malnourished. So by noon, I went with the truck driver and 2 other staff to the hospital in Bow over these crazy, terrible roads. And one of the children went to the Bow Children's Hospital. That was the one with the pneumonia and malaria. Straight here. The one with the severe malnutrition went to the government hospital where they have a refeeding program. And both of those children survived, so we were very happy. One was about 6 months, the other was about a year old. So that, and while that was going on, it turned out that there was a woman hemorrhaging in a village that was about 5 or 6 miles away. So one of our other trucks went there with one of the nurses, picked her up, took her all the way to Bow to the maternity hospital, and she ended up having I think she ended up with a C-section, blood transfusion, and ultimately did okay. So that was a busy day, but I think it's actually a fairly typical clinic day where they identify a lot of sick people on those days. So the second big group of programs relate to the birth waiting homes. And birth waiting home is a place for the women to stay when they get near the end of their pregnancy, so that when they go into labor, they don't have to walk for hours to get to the health center to deliver. So they stay at the birth waiting home, which you saw that being constructed on the video, and this is kind of the final product here. This one's a 24-bed facility, and this is a picture of some of the pregnant women that were staying there. And so they can stay there to have access to a skilled level of care at childbirth. Otherwise, if they deliver in their village, there's really not much help. I mean, they may survive, okay, but not all of them do. If you hemorrhage and you're out in the village and don't have any transportation, you're kind of in big trouble. And the most common causes of death for pregnant women are postpartum hemorrhage. Sometimes it's before, or antepartum hemorrhage even. Infection, obstructed labor, and then eclampsia or preeclampsia, the hypertensive disorders of pregnancy. So those are the most common causes of death that we're trying to help prevent or treat quickly. Then the first birth waiting home opened in 2018, and then the second one opened in 2021. And there have been on the video it said 300 women, over 1,100 women have now stayed at one of the birth waiting homes since January 2018. So this is the second one, and this is smaller. This is the area where they sleep, and this is kind of an area where they're an open kind of courtyard area, and then they're outside a lot too. But this one, the maximum capacity is 11 patients. There's a picture of some of them right there. And one of our other trucks.
Carol, how long would it be typical that a woman would be there waiting?
Yeah, so ideally, it would be a week or two. So they would be referred from the health clinic by a midwife when they think they're getting close to delivering. But as I'm sure every one of you knows, it's really hard to predict when you're going to go into labor. And they haven't had the advantage of really precise ultrasounds to figure out even when they're due. So sometimes they'll stay a day and then deliver, and sometimes they'll be there 6 weeks. So it's quite variable. But what we were hoping for was more like about 2 weeks, because otherwise, they're away from their families, and it's hard for them to be there that long. They like being there though. They really like it. So it's like a place of rest.
Yeah, no
They've
kids,
been working.
right?
Yeah, exactly. It's like a vacation. Yeah. And they form these kind of bonds with each other, and they have a lot of socializing going on and some activities. So it's turned into kind of a respite for them for the last couple of weeks of pregnancy. And the nurses or midwives that deliver them said that they're in so much better condition if they have stayed at a birth waiting home, because they're rested, they're cleaner, they're better fed, and so they're going into labor and delivery in a stronger health, better health.
How long do they stay after they deliver?
Well, they usually stay 24 hours at the actual health clinic where they deliver, and then come back to the birth waiting home for another 2 to 3 days. And then one of our vehicles helps transport them to their village or to as close to the villages that we can get. So a few days, more than here.
Yeah.
Yeah. You want you out?
Yeah. So this is Yata, and I'm going to just tell you her story. When I first met her, she was pregnant. This is the first part of our trip last year. And she lived in Kidby. Okay, so I'm going to try to orient you on this map. So Bow, the bigger city, is located up in this area. And then Tikonko, which is kind of the center of our operations, is right here. She lived in Kidby, which is down here, and that's about 6 miles from Tikonko. So without the birth waiting home, she would have waited till she went into labor and then started walking 6 miles to get to Tikonko, which would take who knows how long. And sometimes it's during the rainy season or during the night, and obviously that's just not a good situation. So because this was after the birth waiting home had opened, she was referred to the birth waiting home here in Tikonko, which is right about there. And when she went into labor, then one of our vehicles transported her to the clinic right in Tikonko, which is close by. She gave birth and came back to the birth waiting home for a few more days and then went back to her village. So I would say that this is the example of how it's supposed to work. And it does work this way for the most part. These other villages, I'll just show you. So Tikonko and Gundama are two big population centers. And then around each one of these, there are the 4 outreach clinics. So Tikonko goes out to Lembama, Dodo, Balahun, and Sunga. So those are the 4 outreach clinics that come out of Tikonko. And then Gundama has 4 outreach clinics at Sambahun, Turbema, or Kokofele. Let's see what are the other ones. Galahun, Gandarhun, I'm not even pronouncing these right. And then I think that's Macbima. So each of them have, well, that's Macbima right there. Yeah. So we have an epidemiologist that's on our board, and she's figured out how to do all this mapping. So it's been really helpful. And right here are the 2 more remote health units that we partner with, Sambahun and Kasama. And part of their catchment area is across the river. So when those women go into labor, they have to cross the river. And there has been an occasion where they've drowned trying to cross the river if the water level was really high during the rainy season. So we're trying to figure out ways to better serve this more remote area. So the third big area of our programs is the child health programming. And a lot of that is at the motorbike outreach clinics where they're seen for illnesses. And then there's also child malnutrition program that goes on there. And over 30% of the children in Sierra Leone are stunted in growth. So there's a big problem with malnutrition. And we were very lucky to be able to hire a university-trained nutritionist from Sierra Leone that runs our healthcare programs, our malnutrition programs. And we use the local country guidelines, World Health Organization guidelines, and then we use something called Plumpy Nut. Have anybody heard of Plumpy Nut? It's kind of like a peanut butter product that comes in a little packet, and it's got 100% of the nutrition that you need. So for children that are severely malnourished, they're supposed to get, depending on their size or their age, a certain amount of that every day. If they're so severely malnourished they can't even eat, then we transport them to the government hospital for the refeeding program. So we purchase a lot of this Plumpy Nut for this program. And then the second product that we use is called Benny Mix, and it's kind of like a porridge that's fortified. So it's a complete nutritional supplement for the babies too. This is an example of how they measure. Anybody ever seen anything like this? They use a tape measure around the mid-upper arm circumference, and based on that you can determine if they're mild, moderate, or severely malnourished. And it's a little tricky measurement, but it's supposed to be pretty accurate. Then the other part of the child health programs is the children that need hospitalization, and for the most part that's due to severe malaria. So malaria is a huge problem, and the government is not able to supply all the medications that are needed. So our organization has had to kind of step in and fill those gaps with a lot of malaria medications. So if a child's really seriously ill, our RHCI staff transports them to the Bow Children's Hospital for care, and then we pay for the care there. And the average cost for a hospitalization for a child with severe malaria is $40 to $50. Wow. And if they hadn't gotten that care, they would have died. Clearly would have died. So money goes a lot farther there. And the average cost for 3 months of that nutritional supplement I was talking about, the Plumpy Nut, is about $45. So $45 to rehabilitate a very malnourished child or save them from malaria. And we just written a small grant to try to get more support for malaria prevention and treatment. And ultimately, there's hope that the malaria vaccine will make a big difference, but it hasn't It's being trials are being done in different countries, but it hasn't come to Sierra Leone yet. So but that's gonna maybe be the ultimate solution for malaria. And then we have a small food security and agriculture program with a large garden that helps provide produce for the birth waiting homes, and also a kind of a demonstration farm. So that the women that are staying at the birth waiting homes, most of them are subsistence farmers themselves. So they're just trying to survive off growing things on their small farms. And so they get some education about better farming practices while they're there. And then these two guys, Shaka and Patrick, these two guys, they are just hard workers out in the sun all the time, working on the garden and farm. So we're very lucky to have them work with us. So then you might ask, well, what is the impact? It's really hard to say we've saved this many lives, so we have to kind of do it more like how many children have we taken care of, or how many women have we served. So everything we do is in partnership with a local government clinic. And for example, when we go out on these outreach clinics, the staff from the local clinic basically staff these outreach clinics, and then we provide them a stipend, because most of the government workers are not paid at all. They work as volunteers. So they're more than happy to work with us and get a small stipend every week when they go out on outreach. So this is all in partnership with an area that has about 25,000 people. And we're focusing just on maternal child health. So I don't know what the men have to fend for themselves, I guess. So in the year 2022, we had 4,451 child health care visits at our outreach clinics, 771 prenatal visits, and the majority of the prenatal visits actually take place at the local health clinics sites, not at the outreach clinics. We have a strong family planning program with over 2,600 family planning visits using pills, Depo-Provera, and implants, and condoms. Those are the four main forms of contraception that are supplied, and the women are very receptive to family planning. And for the most part, their spouses or partners are too, and they don't want to have so many children or have them so close together, they just don't have access to supplies. In that year, over 550 transports of women and children for medical care, and 292 birth waiting home stays. Then treatment for moderate and severe malnutrition in children. MAM is the word for moderate acute malnutrition, and SAM is severe acute malnutrition, which are terms I did not know 10 years ago. Never heard of them. So our program that year had 1,471 visits for over 200 children. And then the shipments and donations of medical supplies that year was about $16,000 worth. And we get a lot of our medical supplies from two big organizations in the Twin Cities. One's called Matter NGO, and the other one is Global Health Ministries. They each have large warehouses where they get a lot of the excess supplies or discontinued items from local clinics and hospitals. So commonly we'll get supplies like gloves or some instruments or blood pressure cuffs, wound care kits, and that from one of those organizations to ship over. This is a picture from just 2 months ago of our staff in Tikonko. And in the background, you can see one of our board members, Marie, who was there, and then Lamine in the background. Lamine is actually, you can see my arrow there, is Alice's son.
Oh.
So he's on our board now. Yeah. He lives in Ohio, so we have a lot of our meetings by Zoom. He was there as well. And Alice has moved back to Tikonko, and she's living there in a house that she had built for herself. So that was always her dream, was to eventually move home after she retired. And she just a few months ago has done that. I'm sure she'll be back and forth a fair amount, and coming back for medical things here too. So we have a very dedicated staff. This is our nutritionist, Umu, and she's measuring this little boy. They really just strip these little kids down, weigh them, measure them, and nobody pays attention to much of anything about clothes there. So he was being evaluated for malnutrition. And on the left is Julie, one of our board members, who this was at one of the outreach clinics. She was just sitting and helping a mother who had several children, and so she was helping take care of the baby. And this is Moses, who's one of our staff, who is helping at one of the clinics too, just taking care of a little kid, little girl, it looks like. So, one of the things I mentioned in the video is that I have found that the wants and needs and worries and everything of people in Sierra Leone just so similar to ours here. They have such strong family units, and they really do try to take care of each other. So very similar. And the Methodist Church is very strong in Sierra Leone. I didn't go to church this time, sorry, but I have been to the Methodist Church there several times, and it's really an amazing experience because they're singing a lot of the same hymns, but with older words and much slower, and sometimes they have drums and some other instruments going at the same time. And we also have been partnering a lot with an organization in Tikonko, the bigger city, that is supported by the Methodist Church in the East Coast in the Virginia area. It's called Helping Children Worldwide and Mercy Hospital. So we use those, we refer some of our patients and staff to that hospital for care at times. We have a good working relationship with them. There must have been a lot of Methodist missionaries back in the day. Yeah, because the Methodist Church is really strong there. These are a few more pictures from our recent trip. This is Alexa, who is our youngest member of the team. She just finished PA school, and she was with some of the community health workers. And she spent a lot of time at the clinics and in outreach, just trying to get a better understanding of how things are working, and brought back what issues there might be, or increased our level of knowledge of how things really work. The Marklate is another word for vaccine. So this is Marklate your child now, don't wait. And then it's got a list of the age when they're supposed to get all their vaccines. And there's not much pushback on vaccines there. However, there's a lot of children that are behind just because they're not getting in to get their vaccines. So through a small grant that we got last summer, we've started a program with 2 nurses going out to check all the children, and they have their vaccine cards, and then try to get them updated. And then they also supply them with vitamin A, which it's recommended to get every 6 months up to age 5. There's a lot of vitamin A deficiency there. And then albendazole, which is an anti-parasite medication for deworming. So they also give it out every 6 months too. And we've been really lucky to get a big supply of this albendazole and vitamin A through a nonprofit organization called Vitamin Angels. So we discovered we have to kind of connect with lots of other organizations to get what we need to do. Yeah. And then recently, these two, Nick and Riley, they're getting married this fall, but they served in the Peace Corps in this village, but had to leave early due to COVID. But they were with us on this most recent trip, and they're so committed to the people of Sierra Leone. And then I was given the gift of a chicken, a rooster. And I'm from a farm, so I thought, oh, this is great. I'm gonna just hold this chicken, you know? But obviously I didn't bring it with back. So, I'm pretty sure that chicken's long been eaten by now. Yeah. And then this is a picture of a little baby that, this is one of a set of twins that was born at the Bow Government Hospital by C-section. And they have a small neonatal unit there where they can supply them with oxygen and other treatments. So that was fortunate that baby was able to get that level of care there. And twins, there's more twins in Africa. I'm not sure why, but we started a newborn home visit program last year and discovered that the number of twins is really, I don't know, almost close to 5 to 10%. And we also discovered that they're the ones that do the most poorly. So ultimately our in-country staff suggested that we start supplementing the mother of twins, every mother that has twins, with extra nutrition. So we provide like 25 kilograms of rice every month to the mothers that have twins, and that's made a big difference. This slide talks a little bit about kind of the mechanics of running a nonprofit, things that you need to do for transparency and accountability. So in the past 3 years, we've done program evaluations with the goal of quality improvement of our programs, and we've made some changes as we were able to improve services based on the outcome of these evaluations. And then the trainings that we've done most recently include basic OB ultrasound. We were able to introduce a portable, very small, tiny portable ultrasound that hooks up to an iPad. And that's state of the art. And so we started doing basic ultrasounds there. That's kind of a program in progress right now because it takes a lot of training to become really good at an ultrasound. So we did training last year and again this year, and we'll continue to do that. We had an ultrasonographer from here in Minnesota come with us in March 22 and January 23. It's really helped a lot. And then there was child malnutrition training for the community health workers, and then the Helping Babies Breathe training for 18 healthcare workers. Expansion, the other thing was the expansion of our healthcare program through age 10 for children. Food security, advancement, collaborating with a local university and the Department of Agriculture and another NGO to try to strengthen that, because obviously if you don't have decent nutrition or enough food, it's hard to be healthy. So we view food and nutrition as key to health, which it is. The newborn home visit program we started, and then this immunization defaulter program. Defaulter just basically means they're behind, but they call it defaulter program. I mentioned that earlier. Now this is a picture of the woman in the middle had triplets. And this was at kind of the beginning of our newborn home visit program, or it was even before that. And at first we weren't sure what support she needed, but it turned out she could not keep up with feeding 3 babies. And so this is very rare we'll do this, but we provided formula for the babies, to supplement for the babies, because she just could not feed them. And they're all doing quite well. So this is our nutritionist, Umu, who checks in on them very frequently and helped coordinate that with providing formula. And then the mother and the father holding the 3 little babies.
Is that their home then?
Yeah, that's, I mean,
The light in the doorway?
Yeah, this is probably their home. Very rudimentary buildings in a lot of villages, a lot of mud brick walls and thatched roofs. So how can you partner with RHCI and its life-saving work in rural Sierra Leone? So I just thought I'd put in some action things if you're interested. Learning more about Sierra Leone and its history. It's got a fascinating history. And asking Sierra Leone immigrants about their country, if you happen to run into them. There's actually 5,000 Sierra Leoneans that live here in Minnesota. Attend an RHCI event. We have a bowling event in August. So Mike, you gotta get a team together. Or any of you. And then we do an event, our main fundraiser of the year is called Taste of Africa, where we have African caterers coming in and provide African food, which is really quite good. And that's in October, so we'll just mention those. Volunteering at an RHCI event, like one of those, just sharing information about the organization. Consider a financial donation, which I know your church has done a number of times. And then we also have a presence on social media and a website too that has a lot more information. And back there I have my card that's got the website on it too, if you want to look that up. And I do have a few of our last year's annual report that's got a lot of great pictures and information in it. So I'm going to close with this slide that shows a mom and her newborn. And then these are twins that was from a year ago, cute little twins, 2 boys. So that's why we do this work, is to provide, what everybody should have is access to good health care at childbirth and as a child.
Oh, thank you.
Okay.
So, yeah.
Nima wafuna